everyone in every dental office. But in the past 50 years, we have been seeing different proposals of different design of different companies with theory behind their proposal of perfect shape of the implant. And we saw the greatest evolution that took place in development in that field. And we can see that small things in design actually makes a very big changes or difference. So we in Cortex company in R&D session, international R&D sessions, we are always looking and we're looking for simple solutions for clinical situations that each and every one of us encountered while working in his office. And indeed, in the last 10 years, we have developed implants and innovative systems that change the therapeutic approach and those situations where it's required. And some funny story that a few years ago, one of our partners, which is not a dentist, he heard the discussion about the drilling protocols and the bone augmentation. He told us, why wouldn't you make some drillless implant instead of fighting or sacrificing the bone and then fighting to restore it back? We of course laughed at him and say, okay, come on, you are not dentist, you are not understanding nothing in biology, physics concepts like stress and strain, so keep quiet. And we forgot about the discussion. Because physics and biology, this is exactly the place where where they are made together. Because implant is a medical device. And we have to understand those factors and integrating those factors in order to promise or provide successful therapy to our patients. And our patients, they don't know much. They want teeth, they don't want implant. They want teeth that will look natural and healthy and which will be placed without any, let's say, traumatic procedures. As much as less invasive procedures. So later on, in some discussion with a friend of mine, Professor Trizi from Italy, which was a part in our R&D team at that time, and we again spoke about the sensation of the patients, and he told us, after questioning his patients, their biggest experience is a trauma because of the drilling. The patients cannot support the drilling sensation and the vibrating in the mouth. They don't like it. So we suggest, we should think about drillless implant. Of course, we couldn't tell him that he doesn't understand anything in biology. He's one of the most important experts in that field. But we had the question, what about the microstrain? You know what? We have the labs, we have the facilities, let's check it out. And let's see. So the challenge was to create a design which will not increase dramatically the microstrain of the implant. So we started the planning. That was the challenge. Development and planning with combination of all the elements that will promise better osseointegration and function of this implant. And we should remember, all of us know that there are main factors which are influencing the osseointegration. Factors which are related to the implant itself, like surface shape, materials, etc., micro-movements, and mechanical stimulation. So the factors which are related to the implant, like a surface, which is one of most important factors, or I can say is a key factor for predictability, success in survival of the reconstruction over the time. And we can see a lot of different protocols of surface treatment of different companies. And most of them, of course, are good, all companies with good results, but none of them are similar or look like the bone except the SLA surface. If you look closely at the SLA, it looks like the bone. It actually says the bone, hey, I'm just like you. Let's integrate together. So if we will examine the publication regarding those different protocols of surface treatment, we can see numerous articles. Very good foundation, basic foundation, scientific evidence, and articles which shows those different protocols, but the most investigated, it seems like, to be an SLA surface. So we are witnessing tremendous amount of research and publication that contribute to accumulated knowledge and experience to create a solid scientific basis for this method. SLA increases the surface envelope 3 to 4 times more and produces hybrid roughness of macro roughness of 20 to 40 microns and micro roughness of 1.5 to 3 microns. Shape of the implant, of course, has a great significance because it's responsible for compression, condensation, cutting stability, loading, and so on. And all the elements like a thread design, finite element analysis show that trapezoidal thread design poses least strain around the cortical bone comparative to other. Platform shifting, not a new concept which moves the microgap from bone level to central position and transforms the connective tissue or biological width from vertical to horizontal position. It's not a new, of course, with combination of a good connection design and plaque control of the patient. In addition to that, it allows us, the platform shifting design allows us to place the implant in subcrestal position, and it's required sometime, and though in other designs, this will not allow placement of a healing abutment or abutment over top without working a little bit more with some bone profilers. But with platform shifting, we can just choose the correct reconstruction type with the correct height and avoid any bone trimming or milling around the implant. It's very important, especially in those cases where we are using a tilt implant positioning. Even if we are placing them in the bone level, the distal part of the implant always will be in subcrestal position, and you know the difficulty to mill the bone with the bone profilers with distal axis and posterior area of the mount, which can be a great challenge for the clinician. So in that case, actually, the platform shifting design can allow us to use a very nice abutment with emergence profile from the center of the implant and to avoid any intervention, surgical intervention, to create a bed platform for the abutment. Materials, of course, very old topic, important topic. We have a lot of different types of materials in the market, tantalum, titanium, zirconium, like rock solid, commercial pure titanium, titanium alloy, etc. But for us, the first choice for making an implant, narrow implants with complex internal connection, was of course titanium alloy because of its capacity of strength and elasticity. Connection types, again, different connection types during the history, but you can see here a very important work of Ziebrich and Professor Wiegel from Frankfurt University, which actually shows the microgap, especially when the platforms are flat between the implant and the abutment, and only the single connection which didn't show any microgap were conical connection like Astra or Ankylos or later on Cortex, which did the same test in the same university. And we are witnessing the movement of clinicians from all connection types to the conical connection types, and this is a report of Gilbert laboratories from the United States, which shows the tremendous transformation because of the quality of conical connection and stability over time. The main reason, of course, as I mentioned, is the microgap, which is formed between the implant and the abutment, and it increases lateral forces when placed on the abutment. So, microgap is formed by elastic deformation of the implant root, and beside that, we can see the effect of micropumps. You can show that by microgap, fluids get into the spaces, when especially we have a large spaces in the interface between the implant and the abutment, and the liquids or the fluids actually they are using as a very good platform for the growth and culturing of bacteria, which is pumping away all the time while the patient's chewing. Screw loosening, another reason to move to the conical connection, because we are seeing that almost 60% screw loosening with external hexagonal, relatively to 6% with internal connections, with conical connections even less. And why is that? Because the main stress doesn't go to the screw, connective screw. It goes to the lateral walls in the interface of the abutment with the implant. While we are pressing the abutment down, we are actually pressing aside the walls of the implant, which trying to rebound all the time back and locking the abutment inside so the screw sits passive. No force on it, no screw loosening. And this is a very dramatic picture. It's a picture from our test that we performed, a fatigue test, when we examining the worst scenario. So we are taking the narrowest implant, 3.3, the longest, with the longest abutment of 5 millimeters, with the biggest angulation of 30 degrees. And we apply 5 million cycles of beating on this structure to see where the fracture will happen and on what torque it will occur. And look where it happens, exactly where we want it to happen. Because we don't want to have that anything will happen to implant. And we prefer that nothing will happen to reconstruction work, the prosthetics, because it's quite expensive. But abutment is replaceable, very easy, just choosing the number from the catalog and you buy the new one. So this is the mode of failure, place of failure, and look at the value, 280 newtons, which is a very high. It's a 3.3 millimeter diameter implant. So very resistant connection. Comparative, the same diameter with internal hexagon. Look what happens. 3.3, the same abutment, 130. Well, look, where's the fracture? So there is no doubt that conical connection is superior. Next very important factor, it's a tolerated and destructive micromovement on the interface of the implant and the bone. So we have to refer to biology a little bit. We are not working with the wood here. We are working with the tissue which responds to trauma, responds to load, heals, injures, resorbs. And primary stability, it seems to be a very big issue. And why is the big issue? Because of the switching of protocols of delay loading to immediate loading. Everybody moves now to immediate loading, and we know the advantages of this approach. But the primary stability, it's very important in order to do so. So this is a graph, everybody knows that from 90s of Ravaranga and Salama. And primary stability actually it's associated with the insertion of the implant into the bone, and the secondary stability, the remodeling process and the bone healing, and the time in between those processes creates this dip, stability dip, or as I call it, the failure dip. So the literature suggests that there is some threshold which we can afford some movement between 50 to 150 microns. It's not zero. And the question, if we can obliterate this dip and to have a better prognosis for our implants. Yes, we can. We can increase the total stability of the implant by working on implant plan, to use more implants in that case, to connect them, to use different, more aggressive shapes of the implant, or conical implants versus cylindrical. Or we can try to prolong the time of, extend the time of primary stability by maintaining necessary stability during the healing period by working on the bone level, by using bicortical implantation, or to use special implant design like Saturn, like Magix. And of course, we can try to enhance the secondary stability by working on the surface of the implant by using rough surfaces, nano-coated surfaces, etc. The third very important factor for osseointegration, it's mechanical stimulation and physiologic range of microstrain. And previous study of Frost actually describes us five types of microstrain. Disuse, when the microstrain is too low, under 400 microstrains, so it will lead to atrophy of the bone and resorption. Physiological low, between 400 to 1000, where the bone will maintain its volume. Overload, mild overload, up to 2500, where we will have increase in the mass of the bone, and over that, irreversible pathological resorption, and in the end, fracture over 6000 microstrain. There is a rationale to use immediate loading because the microstrain or they are creating a better mineralization of the collagen. And immediate loading leads to quicker and qualitatively better peri-implant bone formation, and of course a lot of other benefits for the doctors, for the dental office, etc. And it seems that osteocytes are responsible to measure the strains, and they are induced that by premium cilia, which is processes from the center of the cell, and it bends or flex during the fluid flow, and it's required for also resorptive responses to dynamic fluid flow. So, in the end, we tried multiple types of prototypes, and in the end we finished with 2 of them, the last, to go for further tests. And we performed the microstrain test with the Professor Vienna, which is the head of rehabilitation department in Tel Aviv University. And for that, we used 2 prototypes, type 1, type 2, conventional implant as a control group, dynamics, with the bone gauges. And the interesting thing was that the highest vertical compared to horizontal strain levels were on type 1 of Magix. The highest horizontal compared to vertical were on the control group of dynamics while drilling and while inserting the implant. The type 2 showed the lowest strain level of all the groups. So, highest horizontal level was on insertion of the dynamics implant after the drilling by the protocol. After 24 hours, we checked out the stress release of the bone, and we saw that the least prominent strain recovery was on the insertion of the dynamics group. So we ended up with the final design of the implant was chosen type 2, which present actually the sharp and single lead for slowing the insertion of the implant into the bone in order to give to the bone time to adapt to elastic modification. Conical connection, trapezoidal thread shape, platform shifting. You may be worried about this sharp figure of the implant and the surface area. So we compare the surface area with the dynamics, and you can see in this table that there is almost no difference. The surface area is like the same with the conventional dynamics with the same size. 3.3, 3.8, 4.2. At the beginning, when we performed the test, we wanted to see what's going to happen to the bone, hard bone versus soft bone, by inserting the implant without drilling, just to see how it cuts the bone and what's going to happen to the bone chips. Where do they go? So, in the hard bone, we can see that implant pulls out the bone chips, which you can collect and use later on. And actually, the implant itself creates the bed for itself in the dentist bone. In the soft bone, the implant condenses the bone. And you can see enlargement of the bone volume around the implant. We have performed some animal tests as well. For that, we chose the rabbit model with the Apollonia University from Romania and Tel Aviv University. And here as well, we did 3 groups. First group with drilling only with 1.5 millimeter drill. The second group was 1.5 millimeter drill for all the length and perforation of cortical bone with 3.7 to release the stress from the neck area of the implant, and control group of dynamics. And you can see here, and the average torque of the under drilling with the release of the 3.7 millimeter drill was like the same. The dynamics showed bigger torque insertion because it was bicortical positioning, and the apex of dynamics, of course, it's more aggressive. So it gained bigger torque at the beginning. The bone to implant contact, you can see with the 1.5 drilling, we had a high bone to implant contact 21 days after and 42 days after sacrification, while when we released the stress, we had much less bone to implant contact at the beginning, and of course, full recovery after 42 days, and with dynamics, a little bit less. So, under drilling didn't show less bone to implant contact after the healing period or some bone loss, and the insertion torque was quite nice. Here you can see the histology sections of 3 types, type 1, type 2, and dynamics 21 days and 42 days after. So why to use implantation with under drilling protocol? There is a lot of advantages. Less risk for perforation or fenestration because the implant actually pulls out the bone, increasing the ridge volume. Bone preservation. We are keeping the most important and valuable material that we are working with. High primary stability. It can be a nice and very attractive approach for novice doctors. It actually works like a bone spreader, but instead of having one more kit on the surgical table, we have it in the implant itself, implant doing it, without cleaning and taking care of additional instruments. So, by the properties of the implant, we saw that it can drill the bone, penetrate the bone without any drilling. But of course, we are the instruction and the protocol is to perform some drilling for some reason. While we are placing an implant by rotational forces, the implant itself will naturally fracturing the trabecula and condenses the trabecula aside by creating a cuff of condensed bone, which will later on will be transformed to the lamellar bone, the implant lamellar bone around the implant. And as I told before, the recommendation and the protocol is to perform a drilling for controlling the insertion. Because without that, we can lose the control, and it's provide us a better control. And the insertion should be as into the socket, post-extractional socket, starting with the palatal or lingual inclination and straightening it up. And the very nice thing that you can change it and straighten up the implant while it's already screwed more than half of its length. Very easy for control. So at the beginning, the thought was to use it for upper jaw because of the bone quality and because of the possibility to work with the handle driver to control the insertion. But in the end, we saw that in lower jaw, it works very, very well with drilling of pilot drill. So, like in this case, immediate rotation, and after healing period. Another case of Dr. Lassi, friend of mine, which is a part of our advisory board team. One more case. You can see the defect, buckle defect of the bone, and just by placing Magix implant with undergoing process, enlargement of the ridge without any additional need for bone augmentation. So, as to whether high torque is a problem for implant integration, I can say no, because there are many articles or meta-analysis, which was done by Italian group, which show that there is no significant difference in marginal bone resorption and implant failure rate between implants inserted with high or low insertion torque. As a histological and biomechanical evaluation of the effects of implant insertion torque comparing implant bone healing, it's clear that high insertion torque does not induce adverse reaction in cortical bone and does not lead to implant failure. We can compare it to also densification technique. And this is the research that was been done with the Cortex implants, with dynamic Cortex implants. And also the densification technique showed that it increases the bone volume around the dental implants in low density bone in respect to conventional implant drilling techniques. So it may play a role in enhancing implant stability and reduce micromotion. So at the beginning, when we presented this idea and the reaction, I saw the reaction of the colleagues, which were like mine at first. It reminds me the saying of Arthur Schopenhauer from the 18th century that said that all truth passes through three stages. First, it's reticulate. Secondly, it's violently opposed. And third, it's accepted as being self-evident. So, I'm proud to show you this launching video of this implant, and to hope that all of you will enjoy it in your practice. Thank you very much.